I'll just start with the NHS position. So 1 in 4 NHS staff have reported experiencing harassment, bullying or abuse from patients, relatives and members of the public. 1 in 7 experienced physical violence, and almost 40,000 of those who responded to the survey said they faced discrimination from patients over the last year, which was up 5.8% back in 2015. Racism was and seemingly consistently is the most common form of discrimination, but in 2019 also saw the highest levels of reported sexism and intolerance of religion and sexuality. So, there's a broader, hate crime related sort of theme here as well. NHS leaders confirmed under new standard contract rules, NHS services will be able to protect staff by barring non-emergency care, any patient or visitor who inflicts discriminatory or harassing behaviour towards NHS staff members. So, as I said, I just want to build on some of that context that Beth set earlier from a freedom to speak up perspective, and that's around building a psychologically safe working environment free of violence and aggression. And that's a day-to-day environment where people can feel safe at work in order to grow, learn, contribute and perform effectively in a rapidly changing world. People are often attached to their work and role, and they can feel able to show and employ oneself without fear of negative consequences to self-image, status or career. And I think that's something I'm sure Jude will be able to elaborate on, when we take some questions a little later. The working culture facilitates that willing contribution of ideas and actions to a shared enterprise, and all employees feel supported, credible, respected, and have personal concerns around safety, repeat victimization, and violence risk reduction acknowledged. I think often in healthcare, in really high pressured situations, working in frontline services, certainly in the context of Southern Health and the mental health care providers, it can be a case of suck it up, it's part of the job. And that's something that we're desperately trying to move away from. So there's a real kind of balancing act between what people are accepting and actually setting a new kind of feel for how you respond and soak up these kinds of incidents that Beth was touching on earlier. So, discrimination occurs on the basis of multiple characteristics. It takes numerous forms, from the overt and deliberate to the subtle and unintentional. People's physical and psychological well-being are affected by experience, perceived and anticipated prejudice, stigma, violence and aggression. And just to give you a little flavour of that and what we're kind of referring to, I was speaking to a colleague a few months ago who'd been on the receiving end of some absolutely abhorrent racist abuse from a patient. And she says, Leon, I wake up in the middle of the night, I go to the toilet, I get back in bed, and I cannot get back to sleep because I'm thinking, what is tomorrow going to bring? How am I going to handle it? Is it going to get worse? Is it going to get more dangerous for me? So these, when we talk about that psychological safety, reporting is so important, and that's a major kind of theme of the work that we're currently trying to take forward. And when Ben sort of joins the discussion shortly, you'll be able to kind of get a flavour of where that's going to take us in terms of improving consistency around reporting. So there's already considerable burden on those working in a changing and stressful environment such as modern healthcare. I'm sure everybody's well aware of that and acknowledges that. So the complex burden of discrimination, violence and aggression. So experiencing discrimination, hate, violence and aggression at work is more typically likely to trigger past experiences of prejudice, rejection and discrimination, increase anxious anticipation of future episodes, which I was just sort of touching on previously, and potentially promoting exclusion and avoidance, which is referred to as felt stigma. Connect with other experiences and other domains of our lives in a cumulative manner, and be associated with other characteristics where we've experienced discrimination, intersectionality, multiple jeopardy. It's a damaging, multifaceted, holistic, ongoing, existential experience. Okay, so understanding how discrimination can affect health, and you can see here we've got the kind of societal level, cultural and the institutional racism, individual discrimination at that interpersonal level, and then we move into the psychological, biological, behavioural responses, which leads to negative health outcomes. I'm not going to go too much into that slide, but I will kind of just briefly talk about some of the impact. So research shows that these types of conditions and symptoms can stay with victims for 5 years or more, in contrast to victims of crimes not motivated by hate, which showed considerable improvements within 2 years. So clearly hate can aggravate harm caused to victims, and these are just some of the conditions that we're referring to here: depression, stress, anxiety, shock, fear, insecurity, loss of confidence, anger, insomnia, etc. So what we're doing, partnerships, building partnerships, improving our kind of community resilience and building smarter services off the back of it. So at the heart of everything we do in Southern, I would sort of confidently speak for Solent as well on this, is the health and well-being of those we provide services to and the staff who work for us. And that area of staff is so important. We all have a responsibility to help the Trust fulfill its obligation to minimise risks by identifying and supporting adults, children who may be prone or at risk of hate crime. And we can do that by responding to incidents and the threat from those who promote it, prevent people being targeted, and ensure they're given the right advice and support, and working with police and other agencies to report and support. You can see here, so we've integrated the national hate crime reporting strands into our what we call Ulysses incident and sub-cause reporting system, and you can see there we've got all of the sort of the main strands of reporting, and we've added in, and this came off the back of some advice from one of Ben's colleagues, Professor Neil Chakraborty, to add some additional strands in there. So we've got sex, gender, including gender hostility, so things like sexism, misogyny, which we have had many kind of anecdotal reports on. I'm sure kind of Jude would kind of be able to sort of back that up in some of her experiences and interfaces with staff. Alternative subculture, so for people who are aware of the Sophie Lancaster murder, that is another kind of area that we were encouraged to include. And then we have another other category in there, which is that kind of catch-all, where we bring sort of everything together. I'm not going to go into the sort of the processy stuff too much there because we haven't really got a lot of time. But in terms of shaping a new support offer, we're now, and in addition to the work that we do in-house, so occupational health, our employee assistance program, our freedom to speak up guardians, what we call CISM, so it's a critical incident stress management, our staff network, safe spaces. We're also working with victim support and restorative justice solutions and the police crime commissioner's office to really galvanize that support offer and bring it together in a cohesive way. So a few sort of final points around promoting psychological safety involves consideration and intervention at an individual, team and organizational level. It's about creating safe spaces for discussing and having those and discussing difficult issues and supporting speaking up, understanding why some voices are amplified and others are inhibited, and ensuring the impact of speaking up. And also different communication techniques to foster open, honest and respectful communication. Diversity awareness and anti-discrimination education and training, and effective mechanisms for conflict resolution and trust repair. I say we're working with victim support and restorative justice currently, and for people I'm sure are sort of aware of what some of that involves, certainly from a restorative justice perspective, that's supported, facilitated communication between victim, offender, or the harmed and the harmer in a controlled environment to talk about that harm and the impact of it, and ask questions, and in some situations find ways to repair that harm. And that can be direct, face-to-face in a conference, indirect, mediation or letter exchange. However, the offender must have accepted some responsibility, and involvement is voluntary for both parties. I think I'm not going to sort of go to, I know that we're sort of running out of time a little bit, but just to conclude, building a psychologically safe workspace is a benefit for NHS trusts and individuals who work in those organisations. Healthcare professionals who feel psychologically safe believe it is safe to take interpersonal risks, such as voicing concerns, asking questions, and giving feedback. Psychological, physiological, and environmental evidence shows how threats to safety through perceived discrimination harm well-being, physical health, morale, and individual and collective job performance. And making those workplaces safer involves change and a commitment to change at multiple levels, but has the potential to yield benefits for all involved in delivering and receiving healthcare. So I'm going to hand over to Ben now, who's going to talk about the pilot work that we're doing, which to say is going to cut across 6 frontline pilot sites. So yeah, over to you, Ben.
Thanks, Leon. I'll just get my my screen up and running. Can everybody see that?
Yeah.
Thank you very much. Thank you to you, Leon, and obviously the previous speaker, Beth. And this is all sort of a connected strand, really. But I'll talk to you a little bit about the work that Leon and I are planning on doing, because essentially in order to understand the effectiveness of reporting structures and how much people use them, we've already seen from the first presentation about the attrition rate of people experiencing hate crime, and specifically what we're talking about, experiencing racism and not reporting it. And this is probably something that happens in workplaces up and down the country anyway. But I'll give you a little a sort of an overview of where I'm going with this. So I'll talk a little bit about my background as why I'm speaking to you at the moment, a little bit about my work, a bit about the background of the work that Leon and I are doing. We've just got ethics approval to start this process. So it's been a long time coming. And then some key questions which might in fact get some more questions from you and perspectives from people that are listening through those sorts of things, and then sort of where we go next. So I'll do this as quickly as I can, but I've worked with large organisations before, so worked with police forces, including Hampshire. You may wonder why someone from Leicester, University of Leicester, is speaking to you in Hampshire, but I'm born and bred Hampshire, born in Southampton, so I feel a connection to the southern services that we'll be looking at. In fact, I think one of the sites is very close to where I was born. But I've looked at racial disproportionality and processes within that. I've worked across every area of the criminal justice system. I'm a criminologist by trade. I've also worked with the RAF on issues of equality, specifically racial equality within their promotion procedures. Worked with other NHS trusts, a bit of which I'll share within this presentation as well. But generally speaking, my academic interests alongside institutional policy and discrimination works around fear of crime, violence, and the microdynamics of human interaction. So I'm really interested in both the ingredients of racial interactions, but also in the policy that tries to govern them or stop against them, that kind of thing. So obviously, looking over the last number of years, contributed and worked on trying to gain an understanding of workplace racism and the way that can impact on employment. And this has already been spoken about today in more detail than I will now, but obviously promotion, specifically retention, sickness, safety, well-being, all of those things. And if you look at the sort of the brain drain of staff within the NHS, that's certainly something that needs to be looked at. Obviously, alongside judicial proceedings, there are certain policy failings and perhaps full-scale practice audits that could be done as well. Obviously, I'm particularly interested in the lived experience, so I will be asking, within the work that Leon and I are doing, I will be asking members of staff about their lived experience, about their personal experiences around these things, and trying to understand the literal robustness of the reporting structures, whether people trust those reporting structures, how those wider system stakeholders can be resistors to those processes and those structures, and it can obviously be quite sensitive work because we're dealing with quite fundamental questions as well. So one of the key things that I need to understand is how much do we know? So we already looked at the attrition rate of reporting with that sort of thing, but how much do we know is going on in terms of workplace racism? Lots of this would go unrecorded, so part of my job will be to try and find out exactly how much of this sort of stuff is going on. And we need to know as much as possible about the staff experience. It's one of the things that Leon and I say, that it's the type of work that I'm going to do, certainly in the first phase of our work, is almost unnecessary, because I could probably write quite at length about what type of experiences staff members are having around racism and that sort of thing. But it needs to go beyond what's been officially recorded to understand that lived experience, to try and put experiences of racism within the NHS setting into context. So then I need to try and understand what the current reporting system is like, obviously whether people use it or not, whether when they do use it, if they trust it, if what happens after incidents are reported is something that feels like justice or feels like resolution, because things could be reported and nothing happens. And the previous work that I have done has indicated how important that sort of thing might be. So again, we've got some quotations here from previous work. But talking to an NHS on their perceptions of dealing with management, dealing with discrimination and the management of that, what is the point of speaking up in a position of weakness in a powerful system? It should not be my responsibility. It is objectively obvious. So even somebody of relative power, a doctor in an NHS system, feels like they are in a position of weakness when reporting things like racism. And that would be true whether you go up the pay scale or down the pay scale from that point. And then some further key questions to consider on that. So are the data on reporting outcomes, escalations, what are they currently? How are they escalated? What are the experiences of people that have reported that incident? So specifically trying to understand what the outcomes of those reporting processes might be. And on attempts to address issues of discrimination, again, from an NHS doctor, I've learned the hard way. There's no point. Any attempt to raise a situation has turned 180 degrees. Forgive the swearing. The shit that I've listened to every day, but I better not let someone know that their language was inappropriate. I dare not suggest that someone may have been racially insensitive. I raised it on one occasion. I was given a disciplinary. I was told that I didn't have the right attitude. I didn't understand the culture of the team. It is this cliche, but it is worse to be called a racist than to be one. The sad thing is here that the conduct was inappropriate and I wanted to nip it in the bud. It became a totally different beast. So again, trying to understand, there's probably a wider conversation here, because the main part of our work is going to be around racial discrimination from patients to staff, but there is a much wider piece of work that can go on about how staff interact with each other, but that is probably a continuation piece as well. Again, things that we can already know, but to be able to sort of codify them in a legitimate way. But what's the impact of racism in the workplace? Do we have any best practice examples of how to address it? So the work that Leon and I plan to do is not just going to be looking at issues of poor practice, but if we can find individuals or teams that have in the eyes of the victim successfully addressed issues of discrimination, we'd like to understand how they did it and if that's something that's scalable. So there is a need to recognize success in this process as well. And obviously, do we have examples of poorly managed situations? Those can be much harder to address, especially if the management of those situations goes to an executive level. I don't know if anybody has ever worked within the armed forces or with the police at various points, but it can be quite difficult to have those conversations with people in power in those institutions. What is required to support staff members? Importantly, what staff feel they need. So again, it needs to come from users of those systems. So again, NHS Doctor on how racism impacts service users. The bias, unconscious or otherwise, manifests in levels of care and the way patients are treated. I see it every single day. I think that has been backed up by some of the infographics that have been shared in previous presentations today. Another NHS doctor. So I just wanted to have my concerns taken seriously in the moment. I've given up hope of those things being addressed in the long term, but on some occasions I have someone screaming the N-word in my face and I want to feel protected in my place of work. I do not feel protected in any way. So again, some more, so I'm rattling through this quite quickly, but some more key questions. I'd obviously like to understand the lived experience of both users, of staff and users of the current reporting strand. What are the barriers to reporting? Those barriers to reporting could be distrust. It could be ignorance of what those reporting strands are. It could be poor management. It could be lots of different things. Some of those barriers to reporting will not be within the control of the NHS. So people, if they have a distrust of systems like that prior to coming to work for the NHS, then there is nothing much that can be done about that. But trying to understand the barriers that are within the control of the trusts and those that aren't. Obviously, the testimonies and user experience and satisfaction is very important, and how we can work towards overcoming those barriers in context and out of context, and understanding where the limits of internal policy might be. So the current reporting structures would have been put in place in the best of faith, but maybe they haven't worked out as intended, and would, to what extent does policy change deal with those problems, or is it, sort of a tick box exercise? So in terms of what's coming next, so I have submitted ethics approval and we have just been granted ethics approval to start this process. I don't know if any of you have ever experienced trying to go through university or NHS ethics processes to try and get pieces of research done, but it's a lengthy process. Obviously, I want to speak to frontline staff about their experiences. I want to speak to the wider system stakeholders, so up into sort of management areas as well, trying to work towards getting a comprehensive understanding across the trust in order to best advise on where the next phases can go, to try and get that sort of baseline of understanding before the new processes can be put live, those processes designed by Leon's team at great length. And that's pretty much it from